of all, I want to appreciate the entire Stoughton team who've put this together. It's a lot of work, and I appreciate their efforts. We're really focused on community health and education, and this has been part of our series. We're proud of it, and we've had a good response from the community. My name is Riyad Musatif. I'm an interventional cardiologist. I'm born and raised here in Wisconsin, and I went to undergrad at medical school in Madison, and I did my internal medicine residency in Milwaukee. I did cardiology, interventional cardiology, and I'm board certified in cardiology, interventional cardiology, nuclear medicine, and I have a board in vascular interpretation and ultrasounds. I'm here to talk about women's cardiac health, and thank you all for joining me. This is a Stoughton cardiology team. These members are accepting new patients. The three cardiologists above have joined Tina DeGroot, who's been in the community all her life, and she's been a real strong supporter of Stoughton Hospital. We appreciate her, along with Jonathan Milton, who is our other nurse practitioner who have been there for a long time. Joining them has been Dr. Michael Krager, who's a board certified cardiologist, and Dr. Ranga Sriram, who's also a board certified cardiologist. And so anyone who is looking for cardiac care, these providers are excellent, and they're accepting new patients. This is me. Again, my official title is I'm the chief of Department of Cardiovascular Disease and Vascular Medicine and Limb Salvage with Zenith Healthcare. And that's a Wisconsin company who is focused mainly on local community health, especially rural health. I was born and raised in a small town in Wisconsin. And I am proud to serve our state. So why do we, now let me just kind of launch into it. Why do I care, or why should you care, as far as women, about heart disease? Well, many of you may know this or not know this, but it is the leading cause of death in women. And this slide just kind of show you of all the things that we care about or we worry about, how it relates to actually heart disease. So if you look at the small dot on the right, that's how many women die in war. War has been, obviously a big topic. You can see the small circle of women who die in pregnancy and birth. That used to be a lot bigger problem, but that's improved. Medical complications. It's kind of weird to say murder, but you can see murder is there for women. Undetermined deaths, mental health disorders, transport accident like car accidents, suicide, musculoskeletal disorders, diabetes, non-transport accidents, infections, kidney disease, digestive disorders, nervous system disorders, respiratory disorders, and cancer. Heart disease and circulatory problems carry a higher risk of death for women than all of those things I just mentioned combined. So heart disease itself is still the number one killer of women in America. Out of 3 women are affected by this. Heart disease kills 1 woman in America every 80 seconds. It claims more lives than all the cancers combined. 90% of women have 1 or more risk factors for developing heart disease. 2 out of 3 women who die of heart disease never had a warning symptom. A woman is more likely to die in her first year after a heart attack than a man is. And we're going to go into this and talk about these more in details. You can see our statistics for U.S. women. 1 in 3 deaths can occur from heart disease or associated with heart disease, whereas 1 in 31 will occur from breast cancer. The coronary disease in women is underdiagnosed and it is undertreated. Well, why is that? Well, sometimes symptoms of men and women are not the same. Women have easy to miss symptoms. Traditionally, what you think about a heart attack is like this photograph. People are clenching their chest and their chest hurts and they're grabbing it and they're like, oh my God, I'm having a heart attack, and they're calling 911. A lot of times the symptoms that affect women are different. Sometimes they can be very vague. Women can complain of nausea, they complain of fatigue, they complain of shortness of breath when they exert themselves, lightheadedness, dizziness. They can also have chest pain. Sometimes that chest pain presents itself as back pain or jaw pain. And you can see for the medical community, those symptoms can be a lot of different things. And so heart disease was not typically what they thought about. Half of the women present with a heart attack never had any prior warning symptoms as well. So that it seems to come on suddenly. The other thing is more women have, sudden cardiac death and had no prior symptoms. The problem for women is that traditionally heart attacks were more believed to be men associated with being a male. And a lot of that had to do with habits. So in the early 1960s, the majority of adult men, approximately 50%, smoked, while women did not. But the trend changed from the mid 1960s to the early 1970s. Women began to smoke, and they began to smoke at younger ages, and they began to picking up cigarette smoking at a rapid pace. And a lot of that was associated with the liberation movement and the targeting ads of women, like ads that said, "Hey, you've come a long way, baby," and they would have a person smoking, or they would have a strong women figure like a superwoman, and they associated smoking with liberation. And when women started smoking, then those same factors that cause heart disease in men started occurring in women. And because traditionally all of our medical community believed that these were more associated with men than women, and the symptoms of women, as I described earlier, really didn't match the way the book described heart disease. Unfortunately, a lot of that went missed. Now, obviously, we're more aware and that heart disease occurs equally in men and women, and we're more in tune to the symptoms that women develop. And that's where that last thing says women were treated differently based on a gender bias. And lectures like this, hopefully we can try to continue to correct it and make sure that that doesn't happen. Okay, what are risk factors for heart disease in women? I said 90% of women can have one of the risk factors. Well, the traditional risk factors include smoking. They also include diabetes, whether it's treated or not. Obviously, treating helps. High cholesterol, high blood pressure, obesity, and being overweight. If you have some time, if you go on your Google and you just search obesity in America and diabetes in America, and you can look and just put in graph and hit images, you can see the trend of obesity in America over the last 30 years just skyrocket to probably most of the adults in America now are what we consider overweight or obese. And when you become overweight or obese, you develop insulin resistance and diabetes. And these two go hand in hand, and they're very bad for heart disease. As well as physical inactivity. We built a lot of highways. We built a lot of cars. We have buses. Few of us walk anymore. Our life has become very convenient, and we lack the physical inactivity, especially in our home state of Wisconsin. At this time of the year when it's so cold, we're not going to be walking outside and getting that physical activity. Also, family history is important. A lot of people have heart disease. If you ask them their family history, their brothers and sisters have heart disease, their parents had heart disease, their grandparents. And so a lot of these factors that we're talking about run in families as well. Depression is a factor, and so is stress. There's also, on the right, sex-specific risk factors. So women who have preterm delivery, if they develop what we call gestational hypertension, they get hypertension while they're pregnant. Preeclampsia is a fancy word that you get really high blood pressure that can affect the baby as well when you're pregnant. Gestational diabetes, some women while they're pregnant will develop what we call insulin resistance and develop diabetes during gestation. That's a risk factor for developing diabetes later, and it's also a risk factor for heart disease. Autoimmune disease. Some breast cancer treatments, including radiation, can affect it. Something called polycystic ovarian syndrome, functional hypothalamic amenorrhea. It has to do with a gland in your body called the thalamus gland, and it can cause bleeding to stop. Menopause. I mean, not menopause, but women's period. Menopause status and the use of hormones. Many women who had menopause and they would get hormone replacement therapy, along with smoking and others, can affect your risk of heart disease. So let's talk about these more in depth. Smoking itself. Why is that a problem? Well, smoking causes inflammation and it damages our blood vessels, and it can evolve into plaque buildup in our arteries, and that plaque clogs our arteries and causes heart disease. We also have good and bad cholesterol. Something called HDL is actually our good cholesterol, and when you smoke, you reduce the good cholesterol. And that good cholesterol is the cleaning function of cholesterol. It goes through your body and cleans out bad stuff. And when you have less workers to clean up, well, then the arteries are going to be a little dirty and messy. And that leads to heart disease and heart attacks. Increased blood pressure can affect those blood vessels and damage them and lead to blockages and heart disease. And increase in heart rhythms can be caused by smoking. Smokers who have a heart attack are actually more likely to die and die suddenly within an hour than people who don't smoke and have a heart attack. Women who smoke are at a much higher risk of developing cardiovascular disease based on their own gender. Now, if you quit smoking, that risk improves. You can cut the risk of heart attacks by 1/3 within 2 years of quitting smoking. And if you've quit smoking for 10 to 14 years, your risk of heart disease goes down to that of somebody who never smoked. What about obesity? Well, in the United States, 34% of our adults are overweight, 34% are obese, and 6% are extremely obese. This is a plague on our nation. It's also a sign of America's prosperity. Food, although we used to say food was relatively cheap, obviously with inflation, I don't think it's cheap, but you get the point. We have plenty of food, and it's easy to access. You don't even have to leave your house now. You can click a button on your phone and they'll deliver you a pizza or a hamburger. And that's made it very difficult for people. And our portion sizes are extremely large. That in combination with our inactivity, most of people have a car or can take a cab or an Uber. And so we don't kind of walk anymore. All those things have led to us becoming overweight. Now, the way we measure whether somebody is overweight, we use an index. It's called a BMI. You might have heard of it. That stands for body mass index. And we basically take your weight in kilograms. And the way you come up with the kilograms is you divide your weight in pounds by 2.2. And so every 2.2 pounds is 1 kilogram. And we divide that by a person's height in meters squared. And those are the kind of averages. If your BMI is less than 18.5, we consider you underweight. If your BMI is between 18.5 and 24.9, we consider you healthy. Overweight is over 25. Obesity is a BMI of over 30, and morbid obese is a BMI of over 40. There is a 30% increase in heart disease risk for every 5 units of increased body mass index. So if you think about, you could tell how much gaining weight can affect your risk of developing heart disease. So what is the effect of body weight and coronary heart disease or cardiovascular heart disease mortality among women? And if you look on the bottom, those scores are your BMI, and you can see the relative risk of having CHD mortality deaths. As you go to the right, where you become obese and morbidly obese, your risk can go almost to 6 times what it would be had you not been that much overweight. What about diets? What is the risk if you eat a heart-healthy diet? And I'll explain what that is. The more heart-healthy components you eat in your diet, the less relative risk of a heart attack that you can have. So the diet scores by what we call a quintile, but the consumptions of vegetables, fruits, whole grains, fish, and legumes, if you have a score of 1, which is little consumption, you can see it's almost 2 times the normal person relative to a heart attack, 1.71. But if you consume at least 5 of those things every day, then it goes back down to 1, which is less risk for developing a heart attack. What is our American Heart Association's recommendation for a healthy diet? I joke with my patients when they ask me what they can eat, and I tell them if it tastes good, don't eat it. But the problem with that, and the reason why it's a joke, is because our bodies are trained to like foods that have high calories. If you think about it, if we didn't like food with high calories, we'd be very thin. And if there was a food shortage, or if you got sick, then you can imagine that human beings wouldn't do well. So we're kind of built to like the taste of fats because fats have the highest concentration of calories for them and energy for us. But we also like sugar because that sugar is already broken down in a form that your body can use the energy immediately. And so we're kind of built to like those things. The problem is they're not very healthy for us. So our recommendation is 5 cups of fruits and vegetables per day. They should be fresh if you can get them, not canned, not frozen. And you get some of the frozen, or not frozen, but canned vegetables or fruits, I should say, they add a lot of sugar to them. And that simple sugar is very bad for you. And the fruit drinks. So I don't recommend anybody, you just kind of cut out all the sodas out of your diet. I cut out soda out of my diet. And even I don't even recommend diet sodas. If you can just cut them out, it's tough at first, but then you can develop a taste for it. 3.5 ounces or more of whole grains. So you want to use wheat when you can, bulgur, oatmeal, whole cornmeal, and replace the white rice with brown rice. These are little things that at first you might not like the taste, but you eventually grow used to them and they just become part of your diet. And these are little things that we can do. Fish, we love fish in Wisconsin. I like fried fish, but that's not good for you. You want to use the oily fish that have omega-3 fatty acids like salmon or mackerel, trout or herring. And you want to prepare them in a way that you don't make them bad. So what tastes better, fried or baked? Well, to me, fried tastes better. And that goes back to my original saying, if it tastes good, don't eat it. So you want to try to avoid the fried fish and try to or bake it where you can not damage the fish or the oils, and you're not adding bad oils to it. The added sugar per week, you want to keep that under 450 calories. I mean, that's like 3-4 cans of soda. The processed sugars and syrups are very bad for you. They are our bodies. These are relatively new to the human beings. We never really had white powdered sugar. I can give you the history of that, but I don't think we have time. But that was developed and cultivated. It tastes good to us, but it comes inside you. It causes a huge spike in insulin, more than if you ate more complex sugars and carbohydrates. And that could lead to a lot of damage, obesity, and it can even cause you to want more. Sodium itself, we should try to limit. That can lead to a lot of problems, including hypertension. Some people are salt sensitive, some people are not. But basically, you just try to avoid adding too much salt to your food. What about exercise? Remember, we talked about that we're not really active. Well, does exercise work? How much should we do? How does it help us? Number one is exercise helps in weight loss. It builds muscle, so you're less likely to fall as we get older and break something. It helps with your sleep. It helps with depression. It also decreases your weight. And when your weight goes down, you lose fat. And that helps you improve, if you have diabetes, it'll help improve the diabetes and the blood sugar and prevent you from developing type 2 diabetes. And then your cholesterol, it helps lower your bad cholesterol, your LDL, but it's also the best way that we have to increase your good cholesterol, that HDL. And then remember that HDL goes in your body and cleans plaque out. And so by doing exercise, that's the best way to improve it with weight loss. We don't really have great pills, medications to increase that. We have some, but they're not very good. It'll also decrease people's blood pressures. And we'll talk about how that works. So what is your goal? Well, we'd like to say your goal is 150 minutes, which is roughly a couple hours of moderate exercise a week. Okay. So, I mean, if you're doing, one statistic is if you walk, in addition to everybody who's listening, above and beyond what you're walking now, if you just add 30 minutes of walking a week in total, that's like 6 minutes a day, you would decrease the chance of you having a heart attack, stroke, or death by 14%, just by adding 30 minutes for the whole week. That's how good exercise is for you. And it's free. You want to try to target a heart rate that is within 50 to 75% of your maximum heart rate. So you might ask yourself, well, what is my maximum heart rate? You take the number 220 and you subtract your age from that. So 220, if I'm 100 years old, then my max heart rate is 120. And I want to get to 50 to 75% of that, which would be, 60 to about 85 heart rate. But you can calculate your own. That's the pace that you want to walk at if you can. That's the fat burning cardiovascular kind of zone. And that is different for everybody. And the more you exercise, it'll change for you as well as your body gets used to exercising. So you take the number 220, you subtract your age, and then you take half or 75% of that, and that's where you want your heart rate to be when you're walking. So does it work? Well, you can look here, your relative risk of heart disease just by walking. If you're walking, these are hours per week, and you can see 1 hour per week on the left versus up to 5 hours per week. You can see your relative risk of developing heart disease goes down significantly. And you can look at 4 to 5. So if you can walk up, we really try to push you to walk 30 minutes, at least 5 to 6 times a week if you're possible. That's the best thing to do. And you can see how much that can reduce your chance of developing heart disease just by walking. What about blood pressure? We talked about that as a major risk factor. Okay, well, we'll first look at some classifications of what the definition of high blood pressure is, and then we'll talk about how that affects your heart disease. So what is a normal blood pressure? We talk about systolic and diastolic blood pressure, and that's basically the two numbers that they give you. And so a normal blood pressure, we like to see 120 millimeters of mercury over something less than 80 millimeters of mercury would be normal. Somebody who's pre-hypertensive, their systolic pressure, and I want you to focus mainly on the systolic pressure, not really the diastolic for now, just the top number. So a pre-hypertensive patient would be between 120 and 139. And then high blood pressure stage 1 is when your systolic pressure goes over 140 millimeters of mercury all the way up to 159. And let me just tell you that these are the averages. So if you check your blood pressure 100 times, you'll get 110 different numbers. Your blood pressure will constantly go up and down. And the way to measure it is to have a machine at home and to sit down for 10 to 15 minutes, relaxed, and then check it in the same arm. And you could check it at different times. And then over a long period of time, we could take the average. And these numbers that we want are actually the average. A lot of times when you come in a doctor's office, you can develop what we call white coat syndrome, or just waiting anxiety if you're sitting in a little room and the provider doesn't come in right away, or you're a smoker, or you're hungry, or you got stress in life, you can get a little agitated. And the blood pressure that we check in doctor's offices can be higher than your real true average blood pressure. And so if you're able to afford or get a home blood pressure cuff machine, we advise you to do it. We also advise you to bring that to your doctor's appointments so that when the doctor, when they check your blood pressure in the office, you can also check it at the same time with your own machine just to make sure it's calibrated correctly and you're getting the same numbers. Okay, so stage 1 is 140 to 159 millimeters of mercury. Stage 2 is when your blood pressure is consistently 160 millimeters or higher, and what we would call a hypertensive crisis, where we need to get it down sooner than later, is when your blood pressure is consistently above 180 millimeters of mercury. What about our lifestyle? How does our lifestyle affect blood pressure? You know, a lot of people are focused on medications, but lifestyle can affect your blood pressure as well. So weight reduction, okay? So you can lower your blood. Let me just tell you this. Every blood pressure pill that we administer will reduce somebody's systolic pressure by 10 to 15 points on average. You know, you can have a little higher, a little lower. It just depends on how your body reacts to the medication. But when you lose a kilogram of weight, that's that top line, you can reduce your systolic pressure by 5 to 20. So really, if you at least lose a kilogram is 2.2 pounds. So every time you lose at least 2 kilograms or about 5 pounds, you get pretty close, 5 to 10 pounds. You get pretty close to maybe we can start considering getting rid of one of those pills or reducing the dose. And everybody's going to be different. This is just kind of an average. You might have more or less response to weight loss, but you can see how losing weight, we can get your blood pressure down and try to get you off some of the pills. Your diet itself, not eating the fatty fried foods like French fries and fish fries and fat on meat, and increasing a diet rich in fruits and vegetables, low in dairy fat, like low fat, and reducing your saturated fats. You could reduce your blood pressure by 8 to 14 millimeters. Cutting down your sodium, restricting it to a low level. That means just trying to be cautious and know, especially like our canned foods or our processed foods. Super Bowl's coming up, some of the popcorn and potato chips, they have a lot of sodium in them. And by just cutting down your sodium, you can drop your blood pressure 2 to 8 points. Physical activity itself, even if you don't lose weight, that 30 minutes a day of walking most days of week, like what I was recommending earlier, can reduce your blood pressure by another 4 to 9 points. And then alcohol, reducing your alcohol intake. They say for men, not more than 2 drinks per day for men or 1 for women. You can reduce your blood pressure again by 2 to 4 points. And you can see even on the low end, when you add these up, 2 and 4 and 2, well, there's 8. And then you could get 8 and 16. And then 5 is 21. I mean, that's only 1.5 medications right there, 1 to 2 medications right there by just losing 2.2 pounds and doing those changes. You can get rid of some of your pills. What's the benefit of lowering your blood pressure? Well, it turns out that if we can control your blood pressure, you can reduce your risk of stroke by 40%. You can reduce your risk of a heart attack by 25%. And you can reduce the risk of you developing heart failure by 50%. That's how important blood pressure is. Okay, what about your cholesterol? Well, we say know your numbers. It turns out in America, half of the people have high cholesterol. Nobody knows it. Half of the people who know they have high cholesterol are treated, and half of the people who are treated to goal. That's not a very good statistic, and that's for a lot of reasons. But these are kind of where your desirable numbers are. And I caution you, this is not that accurate, because what is a desirable cholesterol is really based on your risk. So we like to say for general people who have no risks, a good desirable total cholesterol. And the total cholesterol means that we add up all your other cholesterols. And if it's less than 200, that's decent. Your bad cholesterol is your LDL. We want that less than 130. And these are in milligrams per deciliters. But that's not exactly true for everybody. If you have diabetes, or if you have known heart disease, or have ever had a heart attack, or if you've ever had a stroke, then we want your bad cholesterol to be less than 70 milligrams per deciliter, because we know that gives you the best chance of reducing heart attacks, death, and strokes. Moving on to the lower one, HDL, that's your good cholesterol that we've been talking about. We want that 50 or higher in men, 55 or higher in females. And that, like I said, we do have some medicine, but really exercise is the best way to get that up. And the triglycerides, which sometimes reflects your sugar level, we really want that less. It says less than 200, but we really push to get it less than 150. And nothing is better than diet and exercise and weight loss to get that down as well. You can actually cut all your cholesterol down to less than 50% of what it is just by introducing aggressive lifestyle modification with diet and exercise. Okay. And so for all those reasons, I think it's important for women to realize that heart disease is the number one killer of women in America. Their risk of heart disease is equal to men. It's missed often from some historical biases and presentations that vary, that are not classical. And so I encourage everybody to discuss with their primary doctors all these things and have themselves checked and get these addressed. These things are not perfect, but doing your part hopefully will prevent someone from developing this bad disease.